And here are some examples what MRI can bring to the table. So here is an example of diffusion-weighted imaging in acute stroke that shows on the left lacunar infarct, which is a small subcortical confined to white matter tracts area damage. There is a scattered emboli in the middle. This is from bilateral hemispheric embolization from a proximal cardiac source. And on the right, there is a watershed infarct between anterior cerebral and middle cerebral artery territories. Furthermore, multimodal MRI can provide interesting maps. One is diffusion-weighted imaging, which is metabolically dysfunctional tissue that is destined to infarction if reperfusion does not occur. And around it, there could be an area highlighted here in red and green, an area of compromised perfusion in a much larger area in the middle cerebral artery. This could be a tissue at risk, again, if reperfusion does not occur. And MRA on the right shows actually missing internal carotid artery and the middle cerebral artery, the reason for these profound perfusion changes. And so if I see a patient like this with this what's called perfusion-diffusion mismatch and the large arterial occlusion, I feel enthusiastic about trying to reperfuse this patient or augment flow to try to salvage part of the brain that is hypoperfused and in a hope to limit the damage. However, the trade-off obtaining these scans is time. To get all these images usually takes longer than 15 minutes because even in the best centers, patient preparation, access, and timing of sequences altogether contribute to much longer scanning times than CAT scan. Also, what you need to know about magnetic resonance angiography is that it allows you to look at extracranial and intracranial vessels. It can provide you with three-dimensional views from the arch to the circle of Willis and major branches, and particularly with contrast. However, MRA has multiple disadvantages. Flow gaps, turbulence, and flow reversal could be subtracted from the image, leading to creation of the lesion where it doesn't exist or overestimating the degree of the lesion or percent stenosis. Furthermore, only with current resolution, you cannot obtain plaque definition. You need to apply certain coils or certain specific imaging techniques that are not yet the mainstay. In short, we order MRA if we order MRI all the time as part of the package, and because of the frequency of artifacts or false positive or lesion visualization on MRA, quite often magnetic resonance angiography generates another referral for ultrasound testing just to double check if the flow gap or flow absence or in a certain vessel does represent a significant lesion or is it an artifact. So in a sense, MRA and ultrasound, carotid and intracranial ultrasound are very complementary to each other. Now, CT angiography actually has higher accuracy rates than MRA. It approaches accuracy compared to catheter angiography, and for certain indications it is now preferred imaging modality, particularly if it evolves around finding aneurysms or defining certain vessels and planning surgery or other interventions. So, however, it requires injection of intravenous contrast agents. The scanners allow very fast evaluation and may provide you a shot from the arch, neck, all within one injection all the way to the brain. And however, it has disadvantages. It has radiation and it requires contrast agent, and some patients may be sensitive to it. The next slide shows definition of carotid stenosis on CT angiography, and as you can see here, three-dimensional and two-dimensional images can provide a very detailed depiction of the extent of the stenosis, the degree of stenosis, not to mention that you can measure absolute diameter of the residual lumen and make more precise estimation of the stenosis, as well as see calcified plaques and how it interplays with the overall vessel and anatomy, including the jaw and level of vertebra on the neck. Next slide is to summarize what is the role for non-invasive imaging as it applies to the stroke patients, and particularly to mention carotid duplex ultrasound here. Screening requires high positive predictive value. Well, it is true that it is better to overcall the degree of stenosis than to miss a significant stenosis or occlusion. The other thing is, however, you need to have locally validated criteria for vascular testing with ultrasound, and that applies to carotid ultrasound as well as TCD as well as other ultrasound practice areas. Carotid duplex is particularly good as a complementary test to MRI-MRA, and there is evidence that if both agree, if both show the same degree of pathology, then usually catheter angiography doesn't bring extra information, or based on two non-invasive tests, MRI, MRA, and carotid duplex, you can select candidates for either catheter procedures or carotid endarterectomy. The other application that carotid duplex offers is find lesions other than ICA that could be suitable for treatment or carotid endarterectomy or stenting. For example, lesions in the common carotid artery, finding evidence of dissection. That information can be available. Ultrasound can also help identify mechanism of disease or complications. And you can also monitor using ultrasound in real time, and together with other modalities you can show reversibility of brain damage. Now the next slide identifies some of the problems with carotid stenosis detection by using just duplex ultrasound. In fact, it goes to a broader question. When you evaluate a patient with a stroke or a TIA, do you order just carotid duplex, or do you order carotid duplex and transcranial Doppler? In a lot of institutions, transcranial Doppler is not used routinely for evaluation of these patients, and in the next few minutes I would like to make a case why it should be the case to use both carotids and TCD, carotid duplex and TCD at the same time. So, for example, if you look at consecutive patients with stroke or TIA, 50% stenosis is only found in about 15 to 25% of these patients. So, the rest of the stroke patients do not have their mechanism explained by this finding. What if carotid duplex shows high bifurcation? You simply started to see the bulb, but you never saw the exit from the bulb, you never saw ICA on the neck. So that ICA may contain a lesion that can elude detection. What if you found proximal ICA, but high resistance in the proximal ICA, and you don't see the lesion that may attributable to it or cause it? What if you see a long, greater than 2 centimeters shadow from a calcified plaque? Are you missing significant stenosis here or not? Patients may have tandem or elongated lesions, and the velocities and ratios during carotid duplex examination may be simply confusing or misleading. Quite often patients have bilateral disease, and one will have leading stenosis and the other one will have compensatory velocity increase. How do you reconcile these two? And don't forget that some stroke patients may have not anterior but posterior circulation symptoms. So having someone complaining on transient weakness in arm and leg doesn't mean that this patient has carotid circulation symptoms. That may come from the vertebral or basilar arteries.